professors and colleagues, good afternoon. First of all, I would like to thank the organizing committee for the kind invitation, wishing them a successful and fruitful event as usual. My talk today will be about precision medicine and molecular targeted therapies in pediatric acute leukemia. Precision medicine is a growing medical model which is described as providing the right patient with the right drug at the right dose at the right time. This growing model is supposed to substitute the conventional practice of all size fits all practice therapy and improving and guide the immunotherapy and the molecular-based therapy in hematological malignancies as all, and especially in acute leukemias. Hematology has long been at the vanguard of precision medicine since the targeting of BCR-ABL and BMN-RARA translocation, which were the paradigm of precision medicine in cancer. The newly appearing high-throughput technologies, especially next-generation sequencing, sparked a dramatic increase in our understanding of the molecular events that drive hematological malignancies and especially acute leukemia through integration of the genomic, transcriptomic, and epigenomic data of all types and subtypes of acute leukemias. In 2017, it was a landmark for a year for FDA approval of precision therapies in hematological malignancies in general and acute leukemias in special. Regarding pediatric leukemias, the issue is a little bit different. Leukemia is the most common type of cancer in childhood, accounting for about 25 to 30% of cancers in children and adolescents less than 20 years old. Over the past decades, survival rates have steadily increased for pediatric ALL and AML. This success has mainly been achieved through remarkable progress in the anti-leukemic treatment, risk-directed therapy, improvement of the supportive care and MRD detection techniques, and of the most advances in the knowledge of leukemic cell biology, including genomic variations. Yet, even nowadays, leukemia remains a leading cause of death in children and adolescents. Especially outcome of refractory relapsed leukemia remain poor. Indeed, it becomes more difficult to achieve further improvement of survival. This is demonstrated by the survival rates of acute lymphoblastic leukemia, which seemed to reach a plateau, and the consistent non-response relapse rates despite intensified first-line therapy in acute myeloid leukemia. The ever-expanding knowledge on leukemia biology is vital to identify novel therapeutic targets by disclosing the heterogeneity of a childhood leukemia, unveiling the molecular drivers, and understanding the mechanisms of drug resistance. Actually, acute myeloid leukemia and acute lymphoid leukemia have been changed in the last 15 years from just diseases diagnosed by morphology and immunophenotyping to a well-characterized genetic disorders. In addition to the recurrent cytogenetic abnormalities appearing in both types, which will be discussed in details by my dear colleague Nermin Dabbah in the lecture, numerous germline genetic variants and somatic alterations have been identified in either de novo or relapsed childhood acute lymphoblastic leukemia or acute myeloid leukemia. However, finding targeted therapies or targets for therapies in acute leukemia has several limitations. This is distinguishing what are the actual driver mutations. We must distinguish between the passenger mutation, which is inherited one, not disease-causing, and the actual driver mutation, which is the carcinogenic driver in acute leukemia. Determining the mutation hierarchy, as we know, several mutations occur in cases of acute leukemia, which occur first, which occur second, which is the main driver, we must know. Also, multiple mutations and overlapping signal transduction pathways is a great problem to find the actual targets. Standardization of the next generation strategy. Several next generation sequencing strategies, including whole genome, whole exome, which are actually attractive, but nowadays targeted sequencing is getting more favor. It actually allows more coverage, allows more sensitivity, but still having the potential of drawback that missing non-conventional mutations, which are called the black holes. Therapeutic strategies must increase anti-leukemic efficacy, decrease relapse, reduce undesirable off-target toxicities. To date, several new drugs that target genetic alteration have been approved by the EMA or FDA, or some of them are still under development and trials. I will give a brief review about the main pathways and targeted for precision medicine, excluding the CAR-T approach and immunotherapy. First, targeting kinase inhibitors across several signaling pathways. More than 500 kinases involved in the signal transduction process are encoded in the human genome. Dysregulated kinases, mainly serine, thurine, and tyrosine kinases, are of significant importance in carcinogenesis and metastatic spread. That's why the kinome become an attractive target for treatment of various human malignancies. BCR-ABL fits the model of the cancer-driving genetic alteration, as it occurs early in leukemogenesis, diffusely present throughout the malignant clone, and activates several downstream pathways by its downstream effectors, including the BI3K, RAS-RAF pathway, JAK-STAT pathway, and the BCR-ABL oncoprotein has deregulated tyrosine kinase activity, promoting survival and proliferation of the malignant clone. The BCR-ABL mutations occurs in 3 to 5% of children and up to 25% of adults with BALL. In 2016 update of the WHO classification, AML with BCR-ABL has been introduced as a provisional new entity. The first generation inhibitor was imatinib, which is the first potent ATP competitive inhibitor of BCR-ABL. It enters the hydrophobic pocket of BCR-ABL, prevent its signaling with subsequent inhibition of proliferation, induction of apoptosis. And it has limited selectivity as it targeted several tyrosine kinases. And this was, as I said before, the enigma of precision medicine in hematological malignancies. Due to occurrence of resistance by several mechanisms which are BCR-ABL based or non-based, the most important one is the mutation occurring in the kinase binding domain of the BCR. The next generation of BCR-ABL inhibitor were invented, including dasatinib, which is 300-fold higher potency, and in January 2019, it was FDA approved in combination with chemotherapy for pediatric patients more than 1 year with Philadelphia positive acute lymphoblastic leukemia. The third generation, ponatinib, is highly potent TKI, capable of binding to the kinase domain irrespective of the mutations, possessing multi-kinase inhibitor activity, and was FDA approved for adults with Philadelphia positive acute lymphoblastic leukemia. However, in pediatric, it's still in phase 1 and 2 trials for treatment of refractory relapsing leukemia, still not finished now. Another category get benefit from the TKIs, tyrosine kinase inhibitor, is the ABL class C arrangement of Philadelphia-like ALL, which is a subgroup displaying a gene expression signature similar to those with Philadelphia chromosome translocation, despite the absence of this translocation. ABL class rearrangements account for 20% of this class. It's more commonly in children compared to adolescents, and it possesses sensitivity for dasatinib and ponatinib. The second important pathway is the JAK-STAT pathway, which is a signaling pathway, plays a key role in cytokine-dependent inflammation and immunity. It affects gene expression via epigenetic modification through the TET2, ASXL, and EZH2 genes. JAK1, 2, 3 are frequently mutated in a subset of acute myeloid leukemias and the high risk of acute lymphoblastic leukemia. Ruxolitinib is a dual JAK1, JAK2 inhibitor being studied in several clinical trials for treatment of B precursor ALL, refractory relapsing AML, and recently data from preclinical models provided evidence that it may be a good inhibitor and for patients with pediatric acute megaloblastic leukemia. The second category of the Philadelphia-like ALL is those with cytokine receptor-like factor 2 gene rearrangements, which account for 47% of this class. This class possess JAK-STAT pathway activation, coexistence of JAK2 APOR rearrangement, and have a sensitivity for the JAK inhibitors. The third signaling pathway is the FLT3 pathway, which is encoded for a class 3 receptor tyrosine kinase controlling survival, proliferation of hematopoietic cell, and differentiation. 20% of pediatric patients with AML, particularly those with normal cytogenetic AML having FLT3 mutation. It conferred a poor prognosis. Midostaurin is a first-class multi-kinase FLT3 inhibitor. It has been approved in 2017 for treatment of FLT3 positive patients less than 60 years. However, in pediatric setting is still currently under trials for FLT3 mutated AML, CAMT2 arrangement ALL, and another FLT3 inhibitor, quizartinib, is currently investigated for patients with FLT3 mutated relapsing recurrent AML. The second target may be targeting the mutation in epigenetic modifiers. Epigenetics is the modification that are defined as heritable changes in gene expression that are not due to any alteration in the DNA sequence. The main mechanisms of epigenetics include DNA methylation, histone modification, and RNA-induced silencing. The first target is isocitrate dehydrogenase 1 and 2 genes. IDH1 and 2 are early stable mutations occurring in AML. It accounts for about 20% of all newly diagnosed AML patients. They cause hypermethylation of targeted gene, leading to block amyloid differentiation. IDH inhibitors promote differentiation and as a mechanism of action. However, they are not tested yet in pediatric setting, because their incidence is rare in pediatrics. Only evozitinib, a small molecule, is offered an expanded access program for refractory relapsing AML in IDH1 mutated children of 12 years age. The second target for epigenetics is histone deacetylase, which are a key component of epigenetic machinery. Deacetylation results in closed chromatin structure and consequently suppress the transcription of many genes, including the tumor suppressor genes. They were approved by the FDA in 2017 for relapsed refractory IDH mutated AML. However, four histone deacetylase inhibitors have been approved by the FDA. Currently, several studies is carried out to demonstrate their clinical benefit in patients with primary ALL, refractory relapsing ALL, infant ALL, as well as AML. The third target is DNA methyltransferase enzyme. There are other major epigenetic modifications occurring through the epigenetic machinery. They are mutated in 22% of AML patients, and azacitidine and ditistatinib are nucleotide analogs which are incorporated in DNA, resulting in depletion of the enzyme, hypomethylation of DNA, and the induction of DNA damage. A phase 1 clinical trial demonstrated that azacitidine followed by intensive chemotherapy can be used safely for children with relapsing refractory AML, TLL, and newly diagnosed AML, and they are showing a promising activity. Treatment with histone deacetylase inhibitor result in increased DNA methyltransferase 1 acetylation and decrease the amount of the total protein. The combination between both inhibitors result in a superior response and better therapeutic outcomes. That's why the two drug classes are now frequently combined together in treatment of leukemic patients. Disruptor of telomeric silencing 1-like inhibitor. It's a key mediator of the CAMT2A arranged acute leukemia. It promotes gene transcription through histone methylation. CAMT2 arrangement 2A arrangement leukemia are DOT1 dependent for proliferation. Thus, inhibition of the DOT1L showed remarkable effectiveness in MLL rearrangement leukemia. The third target may be targeting of the apoptosis regulator. BCL2 inhibitors as Ventoclax, which is a newly approved drug for chronic lymphocytic leukemia. BCL2 induced transformation by blocking apoptosis. Ventoclax is a selective inhibitor for BCL2. In acute leukemia, Ventoclax has shown efficacy in both AML and ALL, and several studies are carried out now on them. Targeting the p53 pathway, of course, all of us know that the p53, the guardian of the human genome, and the gene most frequently mutated in all human cancers. Wild type of p53 play a central role in transcription regulation of genes involved in cell cycle arrest, DNA repair, as well as apoptosis. Currently, two major therapeutic strategies are carried out for restoring the p53 function in tumor cells. If the p53 is not mutated, just delete it. Prevention of p53 MZ/M2 mediated degradation will increase the amount of the wild p53 in the malignant cell that will carry out its function, and it is now in phase 1 pediatric trial to be tested. If the p53 is mutated, APR246 through restoration of the trans-activation function of the mutated p53, and several reports said that it has a great therapeutic effect. Another target may be cell cycle regulation. Disruption of cell cycle regulation is a hallmark of acute lymphoblastic leukemia. Cyclin D46 activity is negatively regulated by the B16, which is frequently deleted in T acute lymphoblastic leukemia. That's why cyclin D46 inhibitors are a promising strategy for T cell acute lymphoblastic leukemia. Another point of special interest in pediatric settings was the observations that LKMT2A fusion protein activates cyclin 6 that's driving proliferation of this malignant clone in infant ALL and can be inhibited also through the cyclin D46 inhibitors. Other target approaches may be important pathways like the RAS-RAF-MEK-ERK pathway through the MEK inhibitors. These pathway activating mutations are a hallmark for pediatric low-grade glioma as well as relapsed acute lymphoblastic leukemia. There are 2 studies now registered for investigating the role of MEK inhibitors in treatment of refractory relapsing juvenile myelomonocytic leukemia and refractory relapsing RAS pathway mutated acute lymphoblastic leukemia. Another important pathway, the PI3K ACT-mTOR pathway. Upon mutation of this pathway, activation of this pathway resulting in several malignancies, and now there are an arsenal of small molecule inhibitors that act as a key enzyme has been developed. Early studies show that mTOR inhibitor resulting in decreased growth and induced apoptosis in acute leukemia. The last point of interest in my presentation will be targeting drivers of drug resistance. 15 to 20% of pediatric acute lymphoblastic patients may suffer from recurrence and their prognosis is especially poor. Relapsing blast are up to 350 times more resistant to chemotherapy than blast at diagnosis. A variety of genomic approaches have been carried out for examining the diagnosis. Relapsing pairs were used to discover genes and pathways enriched at relapse that are drivers of drug resistance. Targeting such pathways are likely to prevent relapse. These cells are either emerging from a small population of drug-resistant clone present at initial diagnosis or de novo development throughout the course of the disease. The most important mutations occur including nucleoside metabolisms, LNC5C2, ESP1S1, which are 2 genes involved in the thiopurine metabolism, resulting in resistance of malignant clone to that treatment. So switching to another treatment strategy may be beneficial for those patients. The RAS pathway mutations, which will be targeted by MEK inhibitors, as I said before. Epigenetic modifiers, which can be targeted through the different epigenetic inhibitors. And finally, the mismatch repair pathway mutations occurring during relapse, which can be also targeted through switching to another therapeutic strategy. Take-home message: the high-throughput technology sparked a dramatic increase in our understanding of the molecular events that drive pediatric acute leukemia. Genomically defined precision therapies have shown potential clinical benefit in pediatric acute leukemia. Precision medicine will hopefully improve the outcome of pediatric patients. Identification of druggable targets and the new biomarkers is a must. And finally, precision medicine approach face major complex scientific and economic problems. Thank you.
Thank you, Dr. Reham. You cover all the aspects of the molecular landscape of pediatric leukemias. It's a dilemma, of course. And you express it by the easiest form. It's very difficult and problematic. And to my opinion, it's very important to do the molecular panel from the start at the initial diagnosis, because we have to follow. We have to diagnose first to put it in the WHO classification.
If we miss the data at the start, we can never follow the patient
in a proper
way.
Yeah, because I think that in the first few coming months, there will be also the NGS will do the molecular MRD hand in hand with the flow cytometry. Thank you very much. Any questions to Dr. Reham? Okay, thank you.